Welcome to the Impact Education PayerTalkCE program, care coordination for a patient with AMD and multiple comorbid conditions. I'm your host, Dr. Gary Owens. Happy to join you today. This PayerTalkCE program is jointly provided by Medical Education Resources and Impact Education, LLC, and is designated for a half hour of continuing education credit. This activity is supported by an educational grant from Regeneron Pharmaceuticals, and we would like to thank them for their support. At the end of today's program, you'll be able to complete an evaluation, which must be submitted to receive credit. Click Complete Evaluation in the navigation within the activity. Once you complete your evaluation, you must click Claim Credit to download your certificate, or for pharmacists, submit your credit to CPE Monitor. I have the privilege today to be joined by Dr. Adrienne Scott. Dr. Scott is a board-certified ophthalmologist who specializes in diseases and surgery of the retina and vitreous. She is a retina specialist and professor of ophthalmology at the Wilmer Eye Institute's location in Baltimore and in Bel Air, Maryland. Dr. Scott treats patients across the spectrum of vitreoretinal medical and surgical diseases. She's a true expert in this area, and certainly an expert in macular degeneration, diabetic retinopathy, retinal detachments, and more. So, Dr. Scott, it's a pleasure to be able to chat with you today.
Dr. Owens, it's my pleasure, and thank you very much for having me.
Let's get some clarity on the focus of today's discussion. We're talking about patients with AMD, but also those with comorbid conditions. When you think about these patients, what are some of the concerning comorbidities and challenges that you see they face?
It's a wonderful question. I think we have to be careful of patients who are not only just one or not only at risk for just one bad outcome visually from one disease, such as macular degeneration. We also want to be aware of a patient's diabetic status. Do they have diabetes or not? Are they on a blood thinner or not? And these days, there are more and more even exquisite, very, unique blood thinners, and more by the day, that interfere, you can see evidence of in their retinal exam. For example, likelihood of bleeding and less likelihood of clotting. Certainly blood pressure. So same thing. We need to make sure the patient's blood pressure is controlled, and we can certainly see evidence to the contrary on the dilated eye exam. And you also want to be aware of the patient's lipid status. Generally speaking, you want to be concerned if there's elevated lipid profile, then that certainly can manifest on the eye disease, on the eye exam.
Okay, well, thank you so much. And certainly, as a former primary care physician myself, I can certainly understand the fact that many of these patients are older, the fact that it is unusual for people with one chronic condition not to have at least one or more chronic conditions. The triad of cardiovascular disease, hypertension, diabetes often go hand in hand, and your awareness of that, as well as a number of other things that might challenge you as the treating physician and challenge the patient as well, are important to keep in mind. And that's definitely the group of patients we're going to focus our discussion on today. So how do some of these factors influence your treatment decisions for patients with AMD?
Well, I think it's important for a retina specialist or an ophthalmologist to be informed about as much as possible about the latest things that are being prescribed by, for example, the patient's internist or the patient's endocrinologist. So, even as I train, there are medications such as Plaquenil or hydroxychloroquine that we're screening for, that maybe an internist or rheumatologist is putting a patient on for collagen vascular disease that has some retinal consequence. And at the minimum, we screen them differently to really screen for any signs of toxicity. There are certainly the blood thinners, as we were talking about earlier, and then the patients who have a malignancy that's treated systemically. There are certain eye findings or manifestations that we need to look for, from anything from retinal pigment changes to, dry eye and things like that. And so it's important to keep abreast of what's being prescribed for the patient systemically. Hopefully that on a good history and physical, on the history part, the patient will divulge what sort of medications they're on, and we'll be able to educate ourselves on the side effects on which to look for.
It certainly is a multifactorial type of approach that you have to do. I noticed that recently we have a lot more options in the treatment of macular degeneration, drugs that last longer, dosing schedules that we have seen now that you can treat and then extend or contract the dosing schedule. And some of those things sounds like they may be helpful to patients, because it does seem like that coming every month for an intravitreal injection can be not only challenging for patients just to do it, but can be time consuming and that sort of thing. What are your thoughts there?
I think that's spot on, Dr. Owens. I think that when many of my colleagues trained, a lot of what you'll hear is they never dreamed of having medications that could actually improve the patient's vision who have quarterly vascularization from macular degeneration. Nowadays, we are trying to not only improve vision, but we want improved vision at sustained treatment intervals. So we're looking for those medications that are enabling the patient to not only go monthly, but maybe every other month between treatments, or even longer in between treatments. So not only do we want the activity of increased and best vision in driving, but we also want to not necessarily have to have them or their loved ones bring them into our offices for treatments as frequently as we used to.
Yeah, in fact, I read a report that the average time for an appointment for an intravitreal injection was actually an astounding number, almost 12 hours. It includes appointment, preparation, and waiting time, which is really only about an hour of that, but travel time, and then almost 9 or 10 hours of post-injection recovery outcome. How do those things impact your decision on how to treat these patients, and how we may have to, in essence, maybe accommodate some of those issues?
Yeah, it's the key question that many patients, it's such a heterogeneous disease that it can kind of cause someone significant vision problems to have wet macular degeneration, or they can have a milder form that's still considered wet macular degeneration, but not necessarily have as high a treatment burden. So a lot of what we would prescribe as a treatment regimen would be dependent upon how severe the patient's eye or vision loss potential were to be. But it is not something that's fun, Dr. Owens. I have to be very, very transparent. Unfortunately, we use lots of numbing medicine, and then we give medicines in the office. But, things we use such as lid speculums and povidone iodine, known as betadine, can be very irritating to the patient's ocular surface. And depending on the patient, they may not tolerate the injections. Even if you get to a point where you can give them injections every other month or longer, they just don't like it.
Yeah, I can understand that. I've never had a personal experience with it, but you certainly had a very apt description. Let's think maybe of a case example. I'll come up with one, say a 65-ish-year-old male patient who's noticed deterioration of vision. You make the diagnosis of AMD. This will be a relatively simple patient. They have hypertension and maybe a little bit of arthritis, but generally are fairly mobile. How would you approach that patient? How would you start treatment? And then, again, you brought up something like going to later or even treat and extend type of approaches. How would you manage that type of patient example?
So in my hands, I am going to approach such a patient holistically, meaning I want to know, who is this patient? I want to know, for example, is this somebody that has family to bring them in monthly, or is it somebody that has to drive themselves from a ways? So that will certainly influence what I'm thinking about is how often this patient ideally will be able to be treated. The other eye status, certainly, if they see fine in one eye and have some vision compromise in another, that may, alter how aggressive I am or how aggressive the patient wants to be. The typical, how far away they live. So I look at, for example, are they driving 1 hour, 2 hours to our offices for treatment, or are they living, across the street? And, it doesn't bother them to get injections, those types of things. A little bit of arthritis, I think most of my patients do have. So if it's just kind of typical osteoarthritis, typically we don't necessarily think about, that as dictating what type of treatment. My typical algorithm is I do start with aflibercept or Eylea 2 milligrams even at this point, but I do try to follow the clinical trials as closely as I can, meaning that, there's something called the induction doses, which is 3 medications, 3 doses each monthly. And when I say a month, that means 4 to 6 weeks in my head, because logistics often are holidays or office closures or the patient's vacation schedule or something often, is going to get in the way. So I like to give the office staff at least a range of weeks they can choose from. 4 or 6 weeks works for me. And I think that works out generally well. Now, after, regular 3-monthly treatment, I am trying to extend that patient, meaning that I add 1 or 2 weeks onto the interval. So when I see them, so if I give them 3 injection doses, each about a month apart, they know what to expect. And I know what to expect. And I think that's generally, you can tell if this is a disease that's going to respond well, or, when you see them, for their follow-up visit, is it still going to be pretty active disease? If it's pretty active, I continue on monthly. If I feel like the disease is kind of quieting down where it's not as active, then I'll kind of see them at intervals, kind of widening their interval more and more, 1 or 2 weeks in between treatment visits. So when they see me, they're usually getting a treatment, but my goal is to go longer in between visits.
Okay, very good. And it's good to hear that there's some options that these patients, especially the ones that you point out, may be coming from a great distance or have to take even public transportation at times, which can be challenging, especially on the return trip, I'm sure, from your visit. So it's good to hear about that. One of my backgrounds, obviously, as you know, is the payer world, in addition to having been a primary care physician. And payers are charged with that unenviable task of trying to balance cost and access to necessary medicines. And balancing the cost part is always the most difficult part. And these medicines are not inexpensive. And payers have certainly written policies, some of which retinal specialists may agree with, some of which you may not agree with. I understand all that. But in an ideal world, how could we as payers work with ophthalmologists to better help patients coordinate care plans? And this might be a kind of a wish list on your part for things not even medical, but maybe patient support services, because I always took the approach in my role as a payer that the most expensive medication was the one not taken. Those patients who ultimately in your hands either drop out of therapy or go to intermittent therapy. So how can we work as payers with an organization like yours or a practice like yours to better manage these patients?
Well, I think that even just having this conversation is helpful. I mean, it means you know that there are certain things that I see in patient care that the payer may be unaware of, or discussions, regarding what the patient's desires are and how, much their vision means to them, and what my thought process could be behind choosing one medicine or another medicine for this particular patient. But also, my feedback from you, like, what do you see? Like, do you see excess on your end? And is there something that, couldn't we have any sort of compromise where if you try, X medicine, then, you'll not necessarily, as a payer, have a conflict if there were another medicine tried. So that type of thing. I mean, I think that this back and forth is wonderful, and it's personal feedback that we don't often get. For example, you don't hear if I'm on a payer's, highest prescribing, list, or I'm a reasonable prescriber. I mean, that would be good feedback too. Is my institution one of the highest prescribing as far as the funds dedicated to these medicines, or are we kind of within the mean? So I think feedback would be helpful to know how are we doing and what are you seeing? What are you seeing? Because you see things that we don't see at all regarding these medicines. These medicines are click boxes to us, but I think as a payer, it maybe will manifest a little differently.
Yeah, and I think that's one of the issues, and thank you for bringing that up, is we are often working at more than an arm's distance from people like you, and it's very easy for us to make our formulary evaluations or maybe try medicine A before B, which I think we certainly need to bring in folks like yourself to help advise with that. I agree with you. We do need to better profile users of these medications and look for perhaps outliers or maybe even underperformers, those whose average injection rate is less than every other month, or something that may or may not be, depending on which medication you use, less than the desirable frequency. Because again, overutilization certainly indicates waste, but underutilization is waste of a different form, isn't it? Because the patient doesn't derive or may not derive the benefit that they need. So profiling docs, many plans now are moving to something that, for want of a better term, we'll call the Gold Card program, where certain providers get a pass on prior authorizations or a pass on the use of certain medications. That could certainly apply very easily, not only to the treatment of AMD, but DME and DR as well, since the medication overlap is definitely significant. I think something we might be able to help you with, perhaps, we do have case managers for those difficult patients, maybe the ones that are challenged in getting into your office, or maybe some of the ones who don't really have those problems, but still just don't seem to be adherent to therapy. We do have case managers that you can ask us for support. I think we always have to be aware in today's world that these drugs may have significant out-of-pocket cost to members. And is there anything we can do there to help with that? I know there are programs sometimes to provide financial assistance. Often, though, however, that doesn't apply to the bulk of these patients because they're Medicare beneficiaries, where that often isn't available to them except through private foundations. So I think there are many things that we can do to help on your end as well. So all good ideas. Any further thoughts on anything else you'd like to see from payers in addition to what we've just talked about there?
These are great suggestions and very, very helpful. And, I think that there is an accord we can reach. We're not in opposition. We can be of an accord. We just want the person to see better while not being wasteful. And I think there's definitely more than one way to get there. And I think it's even helpful hearing you talk about strategies such as, maybe if I prescribed a certain medicine, that patient will get a certain amount of out-of-pocket costs given their payer support. That would mean something to me, because I think the last thing we want our patients to see well, we want them to see as well as possible, as soon as possible. We do not want them to have some out-of-pocket costs. Certainly that. And that is not something that we as doctors often know, that the patient, like I've had patients even not come in or prolong their interval because they say, I can't afford that medicine. And I want to say, if you'd have let me know, I could have prescribed a different medicine, or we could have talked about a different strategy. But, I think that a lot of times before we know that cost has already been accrued. And sometimes you can get, but you have to go to significant lengths to get anything reversed. So I think trying to know which patients will incur a large out-of-pocket cost or have a significant balance or something like that already would be helpful just to know.
Very, very good. And while we're on the subject of economics, or one of the things that I recently saw an article, and one of the big goals that you have in treating AMD is preventing blindness. And I saw an article, on average, a blind patient consumes about $16,000 plus in healthcare expenditures over and above what an age-matched patient would consume. So I think that there's a real strong financial incentive as well as quality of life gains to be had by working with these patients more carefully. We now do have multiple VEGF therapies. I may be wrong here, but I think I counted at least 5 agents in the anti-VEGF category, ranging all the way from off-label use of bevacizumab to multiple therapies. How can we work, if at all, with trying to find what the most cost-effective regimen is? Do we have any evidence there about cost-effectiveness of any of these regimens?
We have a lot of evidence. That's one thing I think it's a thing that we actually have in common that's, quite good. We have evidence that patients do fine, meaning bevacizumab was shown in the CAT trial to be a non-inferior type of medication to use compared to some of the branded medications. Now that trial is several years old, but there are still some premier institutions that primarily start with bevacizumab, the intravitreal injection, and their patients do fine. That is something I've talked with physicians from premier institutions to start with the bevacizumab, and there's nothing wrong with starting with the bevacizumab. So that may certainly be one option. For example, if bevacizumab is not effective, then maybe a leeway can be given to switch to a branded medication. Alternatively, it would be, again, nice to know before we do any treatment if a patient were eligible for example, for a branded medication from the payer standpoint. Are they somebody that, if it would be helpful to know in advance if they were less likely or more likely to be favorably less wasteful for a branded medication. So it's always good to know kind of in advance what the patient's benefits profile is going to be. And it's very important to also be able to understand. I feel like neovascular AMD is an ongoing disease, meaning you have it for a lifetime. Once it's wet macular degeneration, it doesn't mean necessarily that you have to be treated all the time, ongoing for the rest of your life, but you have to be watched for that. I feel like diabetic macular edema is a little bit more forgiving. And, one of my colleagues talks about it burning out after a certain time where the diabetic macular edema is not so severe. And maybe you could watch it, every 2 to 3 months. Versus diabetic retinopathy is a whole other issue too. So I think keeping in mind the patient's eye disease is really important because that tells a lot about how many injections they may need throughout their lifetime. So we're very fortunate that there are these, robust randomized clinical trials that have helped guide our way. So we know we're not doing anything detrimental because we have evidence and clinically based evidence that this is the patients kind of do well on a non-inferior, non-branded treatment, as well as the, high dose branded treatment. It just kind of depends on the patient.
Well, it certainly sounds like there's a lot of moving parts, and as in a lot of things in medicine, there's a bit of the art as well as the science of medicine, and you seem to have some good comments there that blend both aspects of that. And the ultimate goal of both payers and treating ophthalmologists like yourself is we really want these patients to benefit the most from the medicines they get, improve their quality of life as much as possible, and also be as cost effective as possible. So I really do appreciate you sharing all of those comments. And with that, I'm going to turn it over to questions from the audience. It's been a very interesting conversation, and I always enjoy these types of conversations that help us align some of the issues you face with some of the issues payers face. We talked earlier about comorbidities, and I know you mentioned things like arthritis is common, but are there some comorbidities for patients with AMD that are more concerning to you than others? And what might those be?
There are some studies that show that systemic hypertension or high blood pressure may increase one's likelihood of a worse prognosis in macular degeneration. And certainly, we do have very rare patients that have both diabetic macular edema and macular degeneration. That makes their evaluation and treatment a little bit more complex because they have two different diseases. So, those are the big ones you have to watch: your OCT, your imaging findings in patients that have rheumatoid arthritis, and they may be on Plaquenil or hydroxychloroquine therapy. I mean, it's so the patient can have macular degeneration, but other systemic issues that confound the diagnosis and management with their retinal imaging as well.
Yeah, some of these can get quite complex, and I'm sure give you some challenging moments, especially when they have more than one retinal disease simultaneously. And so that leads into another question from the audience. And we talked about things like treat and extend and some of the challenges patients have accessing treatment. Do you see greater adherence or patient satisfaction with some of the longer acting agents in the anti-VEGF category?
It's interesting. They're new enough where I'm trying to figure out what the place would be and for whom the new agents work best. Essentially, the prior agent, Eylea 2 milligrams, tends to work very, very well. And we have good success with using that in a treat and extend protocol. And just to refresh the memories of our audience, the treat and extend is when you're there with me, or the way I tell the patient, when you're there with me, we give you a treatment. But we try, if there's no fluid or your disease seems quiescent, we can extend our treatment therapy, our injection therapy, 1 or 2 weeks. And it's nice. I think that does help the patients a lot because when they're with me, they know what to expect. They're getting a treatment, but know that I try to increase the treatment interval. And, if their disease remains quiet and based on their retinal imaging. So, it kind of depends. It's a very heterogeneous disease. I mean, I do think it's important that the patients know they have to get these injections or at least be monitored for a lifetime because the disease, unfortunately, even after we wean you off treatment, can come back. So you always need to be monitored by a retina specialist for disease recurrence.
Okay, well, thank you for sharing that insight, especially about the individualization of therapy. It looks like we have one more question and probably time to answer that. And despite the fact that you mentioned individualization of therapy, is there a dosing regimen that the payers could use as a benchmark for appropriate care? Certainly, probably wouldn't be less than monthly, but it might be greater than that. Or is it just too individualized and that we need to just have a better understanding of that individualization of therapy?
Yeah, that's a very good question, Dr. Owen. So it is very heterogeneous and you call it treatment burden. So it can vary quite a bit from patient to patient. And then some of the newer agents are, promising treatment extension up to 12 weeks or 16 weeks. But, those clinical trials won't be necessarily applicable to the general population. So it's the type of thing we're really learning in the community, i.e. real world, how, long acting these agents are. Because as individuals in retina practice, we tend not to tolerate disease activity, whereas maybe they were mandated in the clinical trial to do so. But generally speaking, I like to do the treat and extend interval after the first 3 doses of the treatment. We call them loading doses. After that, we try to extend them as much as possible. And I think to maintain the disease quiescence, and I think payers would understand that. I think patients, again, they kind of like that regimen. They know what to expect. And then me as the retina treating physician, I have a plan with the patient and a goal of trying to extend them farther and farther in between treatments.
Okay, so I think what I hear there is there's still a fair amount of individualization, but experts like yourself know which patients that's going to work for best and those which it doesn't. So I think it's good word and good advice to the payers that there may not be a hard and fast regimen here that we have to do. So once again, Dr. Scott, I really want to thank you for your insightful discussion. It's certainly been educational to me, and I'm sure it has been to our audience. I want to thank Regeneron Pharmaceuticals for their support of the activity. And to claim credit, you need to click the complete evaluation link in the activity. And once the evaluation is complete and submitted, you'll be able to select the type of credit you require. You must claim your credit to receive your certificate, or for pharmacists, submit to CPE Monitor. And it's very important to do all this because we want you to get the maximum benefit as well as to get your credit. And with that, I'd like to thank our audience again and conclude today's webcast. Everybody have a great day.